Hi there, my name is John. I work for Zoll Medical. I'm part of the clinical deployment team, and today we're going to talk to you about real BVM help and TBI dashboard. So before we start talking about real BVM help, let's talk about how BVMs can be dangerous. It's not something we talk too much about in paramedic school, but let's have a little discussion on that. How can a BVM be dangerous? Well, it has everything to do with how we're ventilating our patients, the rate and the tidal volume, because those two numbers can change somebody's CO2 levels very, very quickly. That's why when we ventilate somebody, you're constantly keep it in that narrow range of 35 to 45 to make sure we don't cause any harm to our patients. The problem is if we don't keep a good rate and a good tidal volume within a very narrow range, our carbon dioxide levels will get changed. We know if we hyperventilate somebody, we blow off that carbon dioxide and those numbers get lower on our end tidal. We know if we slow respiratory rates down, that will help retain some of that CO2 and the carbon dioxide levels will go up. The problem is when we do that, we're not keeping very, very good, accurate measurements of our rate and tidal volume. We're just kind of titrating it back and forth and we're not getting any real consistency. So what we have to do is we have to try to get a very accurate rate and a very accurate tidal volume so that when we get those two numbers, we're able to get a good minute volume to keep their levels in a very good range. So the problem is when somebody's CO2 levels get out of whack, we throw their pH levels off, and when we throw their pH levels off, now we're causing cellular damage and death. So in those alkalotic or acidotic states, cells begin to get damaged, and that's what we want to try to avoid with a BVM. We know that when we're using a BVM and we're squeezing, we're on scene, we're talking to the family members, we're trying to figure out which hospitals we're going to be transporting to, we're assessing the scene for any kind of clues that might tell us what is going on or happening with our patient or what caused them to be in this position. We're getting a sample history, we're looking at all the OPQRST questions and trying to answers to them, and all along we're trying to count our respiratory rates. And it's very difficult to do that when we've got 15,000 other things going on in the back of our minds. So the problem is we realize that it's very difficult to do and we're not very good at it. We don't get very accurate numbers trying to do that. We also know that when we're trying to squeeze a BVM, we have no idea what the tidal volume is that's actually going into our patients. Matter of fact, every time we squeeze that BVM, a different tidal volume comes up and we're not getting very much feedback as to how much tidal volume is going out, with the exception of what our end tidals are, and we're trying to maintain them within that range. So that's why Zoll came up with a really clever device. It's called Real BVM Help. And just like our real CPR help, it's going to guide you in how to ventilate your patients. The components you're going to need are an X Series advanced monitor, along with this cable right here. This cable attaches to the side of your cardiac monitor. And then we have this little adapter, looks kind of like an EKG electrode, that's going to go on and attach to a bag valve mask. So when you take a bag valve mask, we have to also have another adapter that goes onto it, and this is what that adapter looks like. So we're going to take that adapter, we're going to plug it into our BVM, like so. And then we're going to take the adapter that looks like and plug it in. And notice that electrode can kind of swivel and turn and do a 360-degree turn. It's hard for me to do that with the camera here, but you can see that you can turn it any way you want. I'm going to go ahead and plug it back in, and we're going to maintain. Now, when I use Real BVM Help and I squeeze this bag valve mask, a dashboard is going to pop up on your screen. Watch what the dashboard looks like. This is our Real BVM Help. And notice it's giving me a tidal volume right here. It's giving me a rate of my current respirations right here. And it's giving me an indicator to tell me when to count down and when to squeeze. So when it gets to 1, 0, obviously that's the time to squeeze. These are my default settings. It's set to 450 cc's of tidal volume and a respiratory rate of 10 breaths a minute. Just like real CPR help, if my numbers are green, that's good. If my numbers are yellow, it means I'm a little bit off. So the goal is keep your numbers green. So if I focus on this dashboard, I'm going to look at when it tells me to ventilate. And when I do, I'm going to notice that I've given too much tidal volume here, but notice my rate is now green. Next time I ventilate, I'm going to give a little bit less. My goal is to hit 450. I got 444 on this one. Now I'm at 469, so I'm staying green. This is where I should be. And you'll notice that your respiratory rates are going to be a lot better. Your tidal volumes are going to be a lot better, and you're going to pay a lot more attention to this dashboard. If there's anything that you would like to change on here, you change it the same way you would anything else on this device. You're going to scroll over. This is my real BVM dashboard, and notice because I haven't ventilated, it's flashing yellow, letting me know that there's an issue. If I highlight the tidal volume, this gives me the opportunity to change it. And notice I can go all the way up to 700 or as low as 300, which means you cannot use this technology on pediatric patients unless they're getting a tidal volume greater than 300. And they're all in 50 cc increments or 50 ml increments. If I want to change the rate, I would simply highlight the rate. And I would change it to 16, 14, 12, wherever I want it to be at. Also, if you're doing compressions and you're doing CPR, you can change it to a 30 to 2 rate. And now it's going to let you know when to ventilate your patient. Okay. As you're doing compressions and you get to that point, it'll be time for you to ventilate again. Once you give your 30 compressions, you can go ahead and squeeze the bag. And notice how I'm now green. Okay, there's my 2 breaths. I'm going to start compressions again, and it's going to continue and continue and continue in that fashion. If you want to change it to a different respiratory rate, you can simply highlight it, change it, and now it will keep tabs on it. So just like real CPR help, this is going to be a very beneficial, very useful tool to help maintain your capnogram within that 35 to 45 range. If I turn my end tidal CO2, you'll notice that chamber pops up. It's obviously going to alarm because I don't have my end tidal on there. But it works in conjunction with your end tidal CO2. That is your real BVM help. We're now going to talk about your TBI dashboard. Before we talk about the TBI dashboard, TBI is obviously your traumatic brain injuries. I'm going to shut my carbon dioxide off, and I'm going to take my BVM help out. So there was a study done in Arizona, and in Arizona, this study was called the EPIC study for EMS. It's the Excellence in Pre-Hospital Care. That is where they got the word EPIC from. And in the EPIC study, they identified a couple things with traumatic brain injuries. First, they said it costs $1.7 million a year to treat patients that have traumatic brain injuries. Of those 1.7 million, there's 52,000 deaths a year, 275,000 hospitalizations, for an annual cost worldwide of over $60 billion. So it's obviously a very big part of what we do. And we know that most of the traumatic brain injuries that occur in the field are usually due to falls or MVAs. And this study has identified 2 phases of traumatic brain injuries. The first phase is obviously the traumatic event, the event that led to the problem. So MVA, it could be a fall, falling off of a ladder. Whatever the situation is, the primary phase is that traumatic event. The secondary phase is caused by improper care and management of the patient, and that is by us, by the healthcare providers. Not necessarily EMS, but all healthcare providers, including in-hospital care. So we obviously can't control the first phase, but we have a lot of control over the second phase. So let's talk about that. 2/3 of all patients with major traumatic brain injuries have a Glasgow Coma Scale between 13 and 15 when we arrive on scene. That's about 80 to 90% of our trauma patients right now. So that's a very big part of our patients. And they have a major traumatic brain injury. We know that there's 3 things that worsen TBIs in the secondary phase, and we call those H-bombs. The H-bombs are hypotension, hypoxia, and hyperventilation. Let's talk about these 3 real quick. Hypotension. That's defined in this study as a systolic blood pressure less than 90. And the study found that just one single event of hypotension would double the mortality rate for someone with a severe traumatic brain injury. Also, in most patients with a Glasgow less than 8, we know that 1/3 of those patients will have at least one hypotensive event. When you put that together, one single hypotensive event will double the mortality rate. That's a lot of our patients. So the goal is to avoid hypotension, of course. How do we avoid that? Well, we avoid it by being aggressive with fluids. Completely different than what we've been taught in paramedic school and what we've seen over the years. I'm not asking that you guys go against what your protocols are changing or telling you to do. I'm just trying to show you what these studies are now showing. The next thing we're going to talk about is hypoxia, and in the study, it was defined as a pulse oximetry less than 90. That tripled the likelihood of death from a severe traumatic brain injury. Over 50% of all severe traumatic brain injury patients will experience hypoxia in the field. That's a huge number, and that triples the likelihood that they're going to die. So hypoxia is a big deal with traumatic brain injuries. The next one is hyperventilation. That's associated with a drop in coronary perfusion pressures and a drop in cardiac output. So what's that drop in cardiac output going to do? It's going to cause your hypotensive event that we said we should avoid. It will also throw off your pH levels, causing respiratory alkalosis, and it causes some cells to be harmed in the process because of that alkalosis. We should avoid hyperventilation and keep our end titles between 35 and 45. So like I said earlier, when we went to paramedic school, we were told something completely different. We were told to minimize the amounts of fluid that were given to a patient. Now they're telling us, make sure you avoid hypotension and use fluids to avoid that hypotension. We were also told that hyperventilation will blow off the carbon dioxide and it will reduce intracranial pressure. Now we're being told something totally different. We're told never hyperventilate the patient. That's just what the study found. This by no means indicates that we shouldn't follow our local protocols. You should always follow what your medical director tells you to do. This is just some new research that's coming out that I just wanted you guys to be aware of. So the big deal is we have to monitor our tidal volumes because our minute volumes are what throw off our CO2 levels and cause acidosis and alkalosis. Monitor your trends in the end tidal CO2. That is our goal. So we came up with another dashboard for you. It's called the Traumatic Brain Injury Dashboard. And what that does is it monitors all of your H-bombs for you. It will trend them and show you what they look like. To get there, boomerang, and it brings up a picture of a head that looks like it's kind of wrapped. That brings up the dashboard. When you click on it, it brings up 4 little sections in this dashboard. It brings up your ventilation dashboard that shows you your rate and how you're going to be ventilating. So when you start ventilating your patient, it brings up everything in your real BVM help. We're familiar with that because we talked about that in the prior section. The next thing it's going to do is it's going to bring up your blood pressure menu because remember we said avoid hypotension. And this is now going to display your blood pressures over the last 15 minutes. Here's your time chart and here's your blood pressure. So as you're getting blood pressures, and I just attached this cuff to myself, as you're getting a blood pressure, let's go ahead and obtain a manual BP. There it goes. And I'm going to go ahead and turn off my smart cuff. That way it's not focusing on the QRS complexes on the EKG that's on the rhythm generator. And now I've got a blood pressure. Notice my blood pressure is going to be placed on here. Whenever you turn your TBI dashboard on, it's going to automatically put the blood pressure cuff onto a automatic mode. If you were already in automatic blood pressures, it's going to make sure that you're getting blood pressures at least every 5 minutes, as you can see. If you had it set to less than 5 minutes, it's going to maintain those settings, so you're getting a blood pressure at least every 5 minutes. And every time you take a blood pressure, it's going to mark it with a little plus sign. Those plus signs indicate where your blood pressures are and help you trend them. Once you have 3 blood pressures or 15 minutes of blood pressures, it's going to then graph them for you so you can see where your blood pressures have been running. Again, avoid hypotension. Your waveform capnography, once you turn it on, will be displayed here. And as you can see, it's giving you 3 minutes of capnogram. So you can trend and look at your capnogram over the last 3 minutes. When you put your pulse oximeter on, you'll notice that your pulse oximetry will show up and it will then display inside your TBI dashboard. And we're going to again have 3 minutes of pulse oximetry. So remember what your H-bombs were, right? They were hypotension, hypoxia, and hyperventilation. How do we address those? Well, when we're trending our blood pressures, we can trend where we're at with our vital signs, and we can make sure that we never get hypotensive. If we see it trending down, we're going to get aggressive with our fluids, give them volume to make sure they don't become hypotensive. Hypoxia. Here's my pulse oximetry pleth. We're going to make sure that it stays above 90 and see where the baseline is over here. It's set to 90. As long as we're above 90, we're avoiding hypoxia. We're going to trend those numbers. If we see it trending down, might be a good idea to give supplemental oxygen. So see how this is very, very powerful where you're looking at the trending. I'm going to go ahead and get another blood pressure before the monitor does. So this is going to help you trend them. It's going to show you where all of your trends are at, where everything's going, and the directions your patients are going, so you don't have to go back and look at your report or look at your gloved hand and have to write them all down. End-tidal CO2 is going to address our hyperventilation, and so is our real BVM help. We're going to make sure we're not hyperventilating our patient by following the directions inside our indicator over here with our real BVM help, and then by watching our capnogram, and we're getting a 3-minute trend on the vital signs there as well. That is how we address all the H-bombs. As soon as it gets a blood pressure, we'll look at something else. Should be any second now. There we go. All right, so the next one is going to be plotted for us. Now I want to go in and I want to start highlighting some of the stuff in here. Let's go ahead and do that real quick. Notice, again, I can change the volume and I can change the rate within my real BVM help, just like we could earlier. But let's see some of the differences inside of our TBI dashboard. Notice blood pressure is highlightable. When I highlight it, I can look at the graph. Right now it's scaled to 85 to 150, as you can see over here. I want to make sure that my blood pressures are always above 90, so that's why that line is indicated there. If I want to change the scale to 60 to 180, you'll notice that now it's scaled a little bit differently. I'll go ahead and change it back to the default. I'm going to go over here, highlight end tidal, and now my scale is between 20 and 50 versus 30 and 48, so I can change it there. There is 20 to 48, and then we'll go to 30 to 48. I can highlight pulse oximetry, and you'll notice I can keep the pulse ox between 70 and 100, or I can keep a very tight, narrow range between 80 and 120. Obviously, we want to keep it in that narrow range because we want to focus on that line of 90. We don't ever want it going below there. So we're going to keep it right there. Okay? And as you see, we've got 3 blood pressures. You see how it's starting to trend over here. Okay? One more thing. How does the TBI dashboard and how does the real BVM help come into play when it comes to doing compressions or CPR on your patient? It's a good question. First of all, we know the TBI dashboard is insignificant when it comes to a cardiac arrest because we're not really focusing on blood pressures. We're really focusing on our BVM. Pulse oximetry may or may not come to play depending on how well we're perfusing them, but we definitely do want our end tidal. So I'm going to go scroll over here and I'm going to get rid of my TBI dashboard. And it's going to be gone. We'll remove pulse oximetry. And it's going to be gone by pressing exit over here. And that will take us out of our TBI dashboard. And you'll see we're left with just real BVM help. If we start doing compressions, right, your CPR dashboard pops up. If I go in here and I add my end title, there's my end title capnogram, my CPR display,
Push harder.
and my real BVM help. Notice it automatically went to 30 to 2 because it recognized we were doing compressions. And when we stop to pause to give our ventilations, and we get back on the chest. Once our patient gets intubated, we're more than likely going to want to change that to give us a rate of
Push harder.
Oops. Once our patient's intubated, we're going to want to get a rate of 10 on our respirations. So we're about every 6 seconds. And again, we can keep our capnogram on there. We can visualize our capnogram. We can see what's going on with real BVM help every time we ventilate our patient. And we can look at our dashboard, so everything is in there.